we've looked at the preventive strategies for infection. What do you do once you get an infection? Okay, and why is it important? So the incidence of infections in prosthetic joint infections is about 1 to 2%, depending on what studies you look at. In primary joint replacements, it's much higher in revision. And the important thing is the economic burden of this is quite expensive. So certainly in the UK, it's about 50,000 if you account for whatever stages, whether 2-stage, 1-stage, DAS, and so on and so forth. It's a massive revision burden, and it's increasing as we increase the number of primary hip replacements done. So in the UK, about 100,000 of these go in every year. So you can imagine the burden on infection. And we somehow haven't managed to reduce this. It is an increased morbidity and mortality for our patients, which is our prime goal to try and reduce that. And there is paucity of level 1 evidence in this. And why is it important? Because you have the obvious ones where the patient is unwell, the wound is broken down, and there is a discharging sinus. And those are the cases that it is very easy to diagnose infection. We don't need criteria, whether it's EBJIS or whichever criteria. But unfortunately, a lot of infections could present as a failing joint replacement. So it could be instability, it could be loosening, pain and stiffness, swelling, and malalignment. Okay? So those are the failing joint replacements are the ones that are tricky to diagnose, and that's why you need some sort of criteria. To diagnose a prosthetic joint infection, you would go along the normal course. So you take a history and examination, get CRP, ESR, so the blood markers, you get serial x-rays, and that might be enough for you to diagnose the prosthetic joint infection. Then you have the next invasive stages, so aspiration, biopsy, and EUA, if you take the opportunity. Nuclear medicine and all of the imaging strategies, the role is not that clear. So CT scans and MRI scans are definitely not useful to diagnose infection, but it can be an adjunct. So if you're planning a single stage operation, you can look at pockets of pus, especially if it's tracking along the psoas bursa, if you're thinking about a single stage revision. So they don't diagnose, but they can help plan your approach. If you are confronted with any of these scenarios, unfortunately, then the diagnosis is never in doubt, okay? And you have to be honest to yourself. So the journey for diagnosing or developing criteria is an extensive one. So started with asepsis in 1986, developed criteria in London. They are still used by the National Institute of Clinical Excellence. Then you had the French criteria come through in 2010, the Academy in 2010 again, and then the Musculoskeletal Infection Society was the sort of breakthrough moment in 2011. You had then the Infectious Diseases of Society of America come up with their diagnosis, and the CDC criteria that came further down the line. The International Consensus meeting in 2013 modified the MSIS criteria, and there was a further meeting in 2018, but stopped short of a consensus to modify the MSIS criteria. And more recently, you had the EBJIS criteria in 2021. And the reason for this is goes back to the paucity of level 1 evidence. Like we've seen in the earlier discussions, even laminar flow, which we take as granted, has the literature quite confused. So going through these criteria, so the MSIS criteria, obviously sinus tract communicating with the prosthesis, and where a pathogen is isolated by culture, okay? And then 4 of the remaining 6 criteria, so your CRP levels and ESR levels, synovial leukocyte count, elevated synovial neutrophil percentage, roughly more than 80%, presence of purulence in the affected joint, so that would be an intraoperative finding, and then isolation of the microorganism in one culture, plus greater than neutrophils. For those of you who use histopathology, greater than 5 neutrophils per high power field in at least 5 fields. So PJI could still not be ruled out if fewer of these criteria are not positive. The IDSA definition was fairly straightforward, and that's sort of there to see. And then came the ICM. So these are the weighted criteria that came from Pavisi et al. So what they did is they went through the literature and then assigned a score to all of those criteria. Okay? So the major criteria remain the same, that if you've got a sinus, if you've got positive cultures, that is infected. And thereafter, you have preoperative criteria and intraoperative criteria. And the preoperative criteria remained the same, but each of them got assigned a score. The D dimers got added to it. Okay? So that was the addition to it. And then if it's more than 6, it is obviously infected. 2 to 5, it is possibly infected. And 0 to 1 is not infected. So, but there was the problem with the consensus is that it's hard to get, isn't it? So we struggled to get the consensus earlier in the panel about what we should be doing. And it's the same thing. So the meeting in 2018 stopped short of getting a consensus on these as the MSIS definition. A lot of the European surgeons were involved in this, so they went away, they had their meeting, and then came up with these criteria, which they described as a traffic light system. So you have the green, amber, and red, whereas infection is unlikely, infection is likely, and then infection is confirmed. So you have them, and there are descriptors of each of them individually. So the clinical features come into it now. So if you have progressive radiographs that show lucency, then the risk of infection is high. So you have to have 2 of those criteria to make infection likely. And then you have the synovial count, you have the polymorphonucleus in the synovial fluid, CRP or ESR. Alpha defensin comes into it and can confirm your diagnosis. So in the red column, any one of those criteria are diagnostic for prosthetic joint infection. Okay, white cell count, sort of nuclear imaging came into the EBJIS criteria, and the role of that is still confusing because about 2 years after a primary hip replacement, about 4 years after a primary joint replacement, knee replacement, the nuclear bone scan value is a bit doubtful. Okay. So what is the purpose of all of this? As I said, you have to have diagnostic confidence. If you're calling something, given that some of the infections are culture negative, you have to be able to clearly call something as a prosthetic joint infection to channel the treatment through. It needs to facilitate treatment. It needs to guide you how you're going to do it. Are you going to do it in 2 stages depending on whatever philosophy you have? More importantly, in the paucity of literature, which is convincing, it gives opportunities for research and collaboration. We are comparing apples with apples rather than apples with pears. And that will lead to a better quality of literature, which will guide subsequent management of prosthetic joint infections. So that's the idea behind all of these criteria. The commonality between it, so the major criteria remain the same. If you have a sinus where you're gazing at the prosthesis, that's an infected joint replacement. Okay, if you have 2 positive cultures of the same organism, it is infected. The minor criteria remain the same. A CRP greater than 10 milligrams per liter is still okay. The synovial count, white cell count more than 3,000. Polymorphonucleus more than 80%, again, stay the same. Alpha defensin still gets the same credit. Histology, again, the same 5. Where it starts to differ, we'll talk about the CRP very quickly. So white cell count, which is raised in PJI, ESR can be elevated for a lot longer. And therefore, CRP is a much better marker, both in the diagnosis and the subsequent follow-up of infections. Both can be raised for 90 days, especially in scenarios like these. So inflammatory arthritis, CRP is unreliable. Equally, low virulence organisms may not cause a mount in CRP. It's a non-specific thing, and a negative predicted value of a CRP is much higher than a positive. The alpha Dimension sort of described this, and he described it for a wide range of organisms. It's the lateral flow test, the Synovial test, which is a qualitative test, is available fairly universally, whereas the quantitative test, which is the ELISA test, which measures your titration levels, is not that common. And very few centers have it. This was the main focus of some of the ICM criteria, alpha defensin. But nowadays, the reliability is not as much. We went through a phase where we used Synovial for all our cases, and nowadays we pretty much have stopped using it because the quantitative test, very few labs have it available. So culture period, again, in most areas, sort of your organism will grow within 3 days, but it's important in prosthetic joint infections to culture it for 14 days and sometimes extended cultures for 21 days because something like Propionibacterium may take that long. So it's important that multidisciplinary team and getting your microbiologist on board so that you're sort of giving them a good idea of what you want to be looked at. The additionality in the MSIS criteria, they talked about ESR, they talked about D-dimers, they talked about positive purulence and the synovial CRP. But you see that all of those things have a low score assigned to them. Okay? So individually, they are not going to help you diagnose infection because their cumulative score is unlikely to go more than 6 unless one of the other factors are positive. In the EBJIS criteria, you have the clinical and radiological findings, which are the additionality. Then the intraoperative bit, which is the sonication, which is where you've explanted the prosthesis, you've put it in the Ringer solution, and then you send it off for cultures. And then if it's more than 50 coliforming organisms per mil, then it's positive. If you've used a centrifuge, then it needs to be more than 200. So that's the important bit. And that does increase the yield of the organism, especially in culture negative infections. And the white cell labeled isotope scan is probably the most reliable if you were to think about nuclear medicine. But that has to be taken with the caveats of 2 years after. Lots of biomarkers being looked at, which hopefully we'll explore through the panel discussion. So leukocyte esterase, calprotectin, procalcitonin, which is used in sepsis in any case. The exciting thing is the molecular techniques, the PCR and the next generation sequencing, which increases again the yield, where you look for the DNA of the entire organism or the broken fragments. Proteomics, again, proteins transcribed to the mRNA is another area that we need to look at to try and diagnose infection. This is the McNally paper. Again, bear in mind, McNally was also part of the EBJIS criteria. So interestingly, their study showed that EBJIS criteria were more specific and more sensitive, so diagnosed in about 101 cases as against the ICM criteria, the international consensus from 2018 criteria for 86 and IDSA for 99, okay? Essentially, it's a challenging diagnosis, and the treatment is also equally challenging. The burden is increasing. The consensus is necessary as there is no single test. The Holy Grail is not going to be available. There's not going to be one test that you can diagnose infection with. Therefore, it is a combination of all of those factors where the criteria sit in. The newer biomarkers are of interest, but there is a danger of overcalling infections. And key is MDT decision-making and treatment within specialized units. Ultimately, which criteria you follow depends on which continent you want to follow. So in the UK, certainly, we follow the EBJIS criteria. If you're have a more of an American slant to it, then the MSIS criteria. But whichever criteria you use, be honest to yourself. Thank you very much.